Dr. Torooti Mwirigi is from an organization called M-TIBA. He is a sales and marketing director, and he joins us for this conversation this hour. We want to talk about health insurance. And yes, it's World Cancer Day. Dr. Torooti, very good morning to you.
Good morning.
Karibu sana to the biggest conversation in the country.
Asante sana for having me.
Now, tell us about M-TIBA. Who is M-TIBA?
Okay. M-TIBA, we are an organization whose mission is to give everyone the power to care. And when I say that, I mean that we aim to create affordable and accessible healthcare. I think in the last conversation you were having, you were talking about universal healthcare and rights and things like that. But we believe at M-TIBA that we can get Kenyans affordable and accessible healthcare. And the key thing with M-TIBA is that we do this in two ways, primarily through technology. Eric Muga, you'd know that a few years ago, for you to be able to check your bank balance, you had a card and you'd have to walk into an ATM to check your bank balance. And today, you can easily do it in the studio.
In cities a few years ago.
Oh, it's a few years ago. Okay, yes. It's the same for healthcare and health insurance. Wow. Yeah, the traditional way of doing health insurance was primarily having a card in your pocket. And the only way you could know what your balance is, what your insurance benefit is you have to go to the hospital.
Yeah.
But now with technologies like M-TIBA, you can easily track your healthcare insurance expenses on your phone. And the technology as well helps you even buy insurance. I can tell you without fear that even today, you can go on your phone, on M-TIBA, buy insurance, affordable insurance, and that insurance gets activated immediately. You don't need to fill forms. You don't need to meet an agent. You can just buy it immediately. So as M-TIBA, yes.
So long as you pay.
So long as you pay. I will come to that. That's the affordable part that we know is a big challenge, especially in healthcare. So one way we see as M-TIBA, the key driver is technology. That's the basis. But second, healthcare has very many moving parts. So partnerships is an important part. For healthcare, you need healthcare providers on one side, where people get healthcare. That's another important thing. As M-TIBA, we connect about 4,000 hospitals in Kenya with technology to ensure that people can access their insurance benefits. On the other side, we bring in insurers because these are the people who provide these products, like what you're talking about, outpatient, inpatient, maternity, all these different products. And on one side, we've partnered with quite a number of health insurers. And on this side, we have hospitals and a network of hospitals. So as M-TIBA, our technology tries to connect all these two people.
So you're not an insurer?
We are not an insurer. We are essentially an enabler to ensure that eventually technology and these partnerships brings down the cost of healthcare. That's the thinking.
In the traditional lingo for insurance,
yes,
there's agent.
Yes.
And what's the other term?
There's agent, broker.
Broker.
Yes.
So are you any of those?
We are not a traditional agent. We're a digital agent, if you would.
So are you recognized by the Insurance Regulatory Authority?
Correct. So as an agency, correct. So what usually happens is that for your insurer to be able to reach their intended target customer, you need an interface. Traditionally, it was an agent who would come, sit down with you, give you a form, sign you up. And when we brought this technology, we realized that you cannot provide this technology without necessarily meeting the regulators' laws. So we had to comply with that on one side. Okay. Correct, yes.
It sounds good.
Yes.
What's the cost and what's the benefits package? Because the trick is in the limitations.
Yes. So I'd like to separate a few things. So there's M-TIBA, us, who facilitate this connection, and they're the insurers that we partner with. And on the other side, the hospitals. So what we've been able to do, we've been able to partner with leading insurers who've been now beginning to see this challenge of affordability. And the big challenge with the affordability was that it was this traditional way of doing insurance was quite expensive, and we have understood that as well. So what we've been able to do is partner with them to produce products that are cost effective. And I can give examples. So we've partnered with 2 key insurers, Britam Insurance and Jubilee Insurance, and they're bringing products as low as 4,600 shillings of premium per annum for a person. Yes. And
per annum?
Per annum, per year.
I just want to be sure that it's 400.
4,600.
But what does that get you?
So the 4,600 gets you a limit of 75,000 shillings. So if you get hospitalized for illness,
inpatient.
Inpatient, yes. And if you get hospitalized for a surgery, for treatment, the insurance will cover you for 75,000 shillings. And for quite a number of people, 75,000 shillings is quite a good sum of money to cover you for any in eventuality. So what we have received the same response, like this doesn't make sense. But these insurers have been working, doing the calculations, trying to understand there's a whole segment of the market that have not been supported. And these kind of products will actually provide some form of protection. And then second thing we realized was, you talked about outpatient, Eric, briefly. And the same thing, we've worked with the same partners, and they've developed even for 8,000 shillings, you can get the same package where if you are admitted in hospital, you're covered up to 75,000 shillings. All your bills up to 75,000 shillings are catered for. T's and C's apply. Which
in very small font.
No, that's another thing we can have to discuss. But now, for an extra 3,500, they've also created a network of hospitals where you can now seek services for outpatient unlimitedly. So what we are seeing is the insurers are beginning, and the regulator is also encouraging them to explore and to try out products that meet the need of the market.
Dr. Torooti, so
Yes.
what you're saying basically is addressing one key problem that we've had in this country, and this is uptake and penetration of insurance.
Correct.
So let's just look at the figures before M-TIBA.
Yes.
And let's look at the figures post M-TIBA and what you're projecting you're going to be able to do to address this.
Yeah.
How many people are covered? How many people have taken up medical insurance in this country?
So from the latest study that I've seen, which was a 2019 IFC study, they approximate about 27% of the population have some form of insurance, health insurance. And when they analyzed this same population, the majority of what they call the lower quintile, if I use what was that, a small majority have cover. And for those who have cover, primarily it's driven by the employers. And you know, in Kenya, if you are employed, there's a mandatory insurance that has to take effect. So what we realized is that for a huge majority, they have to spend money out of their pocket for healthcare. It's a large majority. Yes.
Yeah, 82%
Yes.
of the labor force is in the informal sector.
Yes.
Right.
So
16
we're targeting this group.
Correct.
How does this interface with NHIF? Because, how do they interface? Are we saying pay for both?
Is it part of this statistic, NHIF?
Yes. NHIF, you cannot ignore NHIF, considering that for the formally employed, it is a mandatory insurance. And even the government strategy is to use NHIF as the vehicle for UHC, which we are seeing as.
So my question was,
yes.
if I'm in the informal sector,
Yes.
I've now taken my NHIF.
Correct.
It gives me certain cover.
Correct.
You're then saying that there are new products that I can also take.
Correct.
So how will these interface with each other?
So
Is NHIF recognizing these benefits?
yes. So
Yeah.
there are two ways of looking at it. So what we have seen, some products that our partners have created are complementary to NHIF. So there is the complementarity of the two. So you can utilize your NHIF, but you can also have your extra cover. Like the people seated here, your employer probably, I'm making an assumption, has a complementary insurance to NHIF. But we also have, again, there's a whole bucket where now our partners have developed products which are standalone. Whether you have NHIF or not, you're able to utilize and enjoy the
Let me ask, what is it that has suddenly woken up the insurance industry to...
They have not woken up. It's Mwirigi who has woken up. Okay, you ask the question.
He has a very valid, and I'll say it's COVID.
The COVID, wow.
Explain.
Yeah, simple question.
By the way,
Direct
he's
answer.
my whisperer.
Yes.
Every time I want to make a statement, if you hear him, he's not interjecting.
Yes.
He's just adding. Now, you see, now that he has said what I was going to say,
Yes.
I've kept quiet.
Yes.
So now, you,
Yes.
tell us.
From where I sit, and let me make that clarification. From the observation, I've been in the insurance industry for the last 15 years or so, health insurance, and there's been always the need to serve this segment. We know are not served. Again, I love the conversation you had with Dr. Kitui, who was my classmate, and it's the same problems we are trying to address. However, there were challenges over the years. One, the technology was possibly not ready for this kind of efficiencies, because it is expensive to manage insurance with paper forms, hiring people to go into the field and things like that. So what we saw is the need was there. And I'm seeing Eric smiling. So yeah, the need has been there. And with time, what we saw with COVID, and this is from the perspective, is one, human interaction was curtailed. So people who are traditionally selling insurance, one thing, couldn't go and visit their clients or couldn't prospect. So we saw a transition to more digital space. People discussing with their clients on WhatsApp, people trying to send forms via WhatsApp, and people trying to fill the forms and things like that. So we saw a transition where there was a need to move to the digital space. That's one. And two, COVID created the awareness to people that health is important.
Sure.
And if you don't have some form of protection, you will have a challenge when you face the either medical emergency or medical illness.
So, people are seeking healthcare.
Yes.
That's clear.
Yes.
The penetration of insurance, however, is still extremely low.
Correct.
Right? Are there numbers, or are there statistics that show how much folks are spending on a monthly or even in an annual, in a year, how much they're spending on healthcare? Because then the case can be made, you're spending this amount of money on healthcare, whereby you can get insurance and it would cover you for that period, whereby any procedure you needed to go in and get, or any kind of healthcare medication you could go and get, and you would actually spend less. For people to be able to see the benefit of getting insurance, they need to see that vis-a-vis how much they're currently spending when they're going into hospital on a regular, or doing a harambe, this kind of thing, when people get sick. Do we have that kind of information? Because it would fuel, in my mind, the decision for people to get insurance.
Yes. So I think that's a good question, Drew. And unfortunately, the information in healthcare financing is in a bit of silos, primarily because of it's mostly a paper-based kind of industry. So you're not able to get this kind of statistics across the board. But we already have indirect signals that insurance works. One, you've mentioned it, Harambes. We are in countless Harambes. And we also, on the other side, can see the people who have had some form of insurance. The Harambes are possibly not mostly supporting, but the ones who really are struggling are the ones where the Harambe is towards paying the bills. So we already have some anecdotal evidence that first, in terms of cost of healthcare, it's high. So if you get admitted, you're most likely to not be able to have the cash at hand.
Right.
Yeah, because it's we have other competing priorities. But there's also studies shown, even by the World Bank, that medical emergencies are one of the things that push people into poverty. And it's not only a Kenyan thing. It's a global statistic as well. So medical emergencies, things like what we see now, like cancers, cardiovascular diseases, infectious diseases, push families into poverty. So what we struggle with is to show that value of insurance. And that's what we are trying to do as M-TIBA, using the technology to communicate, work with the insurers to simplify products so that people can enjoy the value and say, I need to get insurance. One last comment, because a few years ago, airtime was a luxury. I think now it's a basic need.
Yep.
Yeah, because the telcos have been able to show value. It has impacted our lives. What we need to show is insurance, or whatever it is, what kind of protection. How do we make it known, or make it a way that people know there's value in insurance? So that's what we are trying to do, and we hope to do that.
But Daktari,
yes,
I think it's not that people don't have insurance because they don't understand the value of it. Yes. People actually do. It's a question of priorities.
Correct.
Care-seeking behavior, if you were to look at the list of things that people prioritize, is very low in that list.
Correct.
Because there are other things which they consider to be far more important. So, for healthcare to make sense, it has to be shown that it has a competitive advantage that supersedes everything else that people consider to be important. And even the messaging of trying to get people to understand insurance ought to be the same, because so long as that isn't done, people have their priorities, and health is not one of them.
Siti, let me ask that
this
question.
citizen education.
Let me ask the question, riding on what you're saying.
Yes.
Why is it that health-seeking behavior is not top in the priority? Is it possible that it's because of the associated cost?
It plays a part, but you don't fall sick every day.
That was the point. You're not sick, so you don't see it as a priority.
But it's care-seeking behavior.
It is.
You feel unwell, but then you're thinking, it's just a headache.
Yes.
The cost of seeking attention for this headache
It's a deterrent.
is time, is most probably money.
Correct.
That whole inconvenience, if it was, you have a headache, you walk in there, you say, I have a headache, and they tell you, okay, this is the issue, just go, you're fine, or here's medication, it would be much easier.
Eric,
isn't it?
The economic impact on healthcare or health care-seeking behavior, it exists and it is strong. But even with people who can afford, they still do not think that health is a priority. There are many people who can afford insurance but don't have insurance.
Correct. They can afford it.
Yes, they have insurance because perhaps their workplace
employer
is provided for.
Correct.
And it's mandatory.
NHIF is deducted from your pay whether you like it or not, and it pays for NHIF.
Correct.
But left on their own, they would not. Put it this way. It is a learned behavior that, to put it simply, that we as Kenyans have in terms of how we go about our daily lives and what we think are priorities.
So if we're looking at learned behavior and saying that obviously there needs to be a shift here to get more people covered, because the thing is, you're never sick for 5 years and then something happens and you're destabilized completely. So then what, from what you see, needs to be done to get us to understand these markers? Because like you said, it's not just a thing of the less advantaged. It's even those who can afford it, who are also operating within this same behavior. So what do we need to do?
Again, that's a dilemma we are in as we speak. But what we know is we need to first change how we communicate insurance and the importance of it. We need to make the products for health insurance much more easy to understand. Again, to understand, if you take one of our partners is Safaricom, what they did with things like airtime or data, they simplified the communication and everyone can understand the benefit and it becomes a priority, because now data is considered data is considered high in the list. So we need to have a fundamental shift in how we communicate insurance, how we package it, so that it's not look like it's a thing that I don't need, or it's it's a conundrum, because
you give the example of
Yes.
Safaricom, and
Yes.
where you're right,
yes,
they never stop.
they never stop.
Yes, it's not as though
Innovating.
they bring about. Yes, they don't bring out this and then they sit back. They are all. There's always
It's a front and center
something.
conversation.
Yes,
Can I say question?
Yes.
Based on that,
Yes.
is Safaricom advertises. I think they're the largest advertiser
Okay.
in terms of the amount of their own money that they put to sell their products, and it comes back to them. So why doesn't the industry come together, put money into advertising, and do the public education?
Awareness.
Do the awareness creation, because you're going to say, well, government should do this. But at the end of the day, there's a vested interest. And then the other thing, Safaricom, of course, also invest in their R&D. They have a department that they pay to just come up with ideas.
New products.
And, maybe more than half of those ideas are thrown out. It's great that the industry is waking up, but maybe they need to wake up more to do that public education, to invest in continuous
R&D is,
research and development.
of course, yes.
Yes,
Thank you very much.
Yes. Ni hiyo. Yeah, so is there scope for the actors to
industry.
come together? Yeah.
And I think where I sit, and there needs to be a catalyst to that happening. And one thing I know is technology is the catalyst. Once people can engage with products much more easily, and they're able to interrogate these products, use it, feel it, complain easily using the same technology, go to social media, able to communicate. I think the industry needs to find a way of doing what you're saying. However, remember, the telcos didn't come together to communicate,
put a pool in
to
marketing.
put a
Make a
pool.
decision.
Yeah, so someone needs to take the role, because the regulator has done a good job in trying to provide frameworks for consumer protection and consumer education. It's now the players who need to actively take that up.
But will they?
So maybe M-TIBA
They
can. It's in your interest.
Yes, no.
That's my invoice.
Yes,
Thanking
yes.
you for giving you
No,
business
I
idea.
was coming to where we are. So that's where we sit as M-TIBA, and just historically, M-TIBA is actually one of the innovations that came out of Safaricom's partnerships. So they know, as part of protection, this is an area that I can give you as much airtime, but if you're sick or if you're not well, it's going to affect your productivity as a person.
Look at banks, financial institutions.
Yes.
They also put in a lot of money to develop new products.
Correct.
And to market.
Correct.
And to reach their customers.
Correct.
Insurance industry, and this is a personal opinion which is shared by C.T. Muga,
You know.
The whisperer.
Definitely.
yes,
know.
Yeah.
Yes.
are spoiled brats. Because they have guaranteed business by law.
Are you talking about health insurance or general insurance?
Insurance.
Generally,
As a whole.
okay.
See, health insurance is still insurance.
Yes, it is. I was just trying to confirm.
There are very
Yes,
many.
yes.
So you work in a factory.
Yes.
There must be an insurance product that is taken by your employer for that, right? You work in an organization. That organization is mandated by law to support you in health insurance. You drive a motor vehicle. You are mandated by law to take up a motor vehicle insurance. So they sit back there, and the law says
business will
you
come.
shall come.
Complacency.
No law tells you must take your money to the bank. Well, indirectly, yes, but not like that. No law says that you must buy a phone and only communicate by calling people. So Safaricom and Telcom and the others have to go out and reach for their customers.
Yeah.
These are the guys.
Yeah, but I would say, especially in health, the mandate is for employers is NHIF. So I just wanted to clarify that. So there is a lot of effort by the insurers, especially, and I'll speak with my health insurance hat here. And there's a lot of effort to try to grow the market. The challenge is all these factors that come to play. there is one big element around fraud, and you will know it. You might say it's mandatory, but the big factor that they fight with is fraud. In the general insurance category, which we discussed now, even in healthcare, there are some estimations about 35 to 40% of billing in healthcare insurance is fraud. Yes. So
it's just like government is
yes.
at 40%, by the way, to support budget.
I did.
Yeah, expenditure.
Okay.
Yeah.
Okay. So I think they are trying to work on those elements around trying to avoid the leak, and what now we're trying to see is that with the technologies that they're putting in place, like M-TIBA and other technologies, now they're able to now use technology to hinder fraud, and now trying to face the market. And it's a good position to be in now, to reach out and say, you are not covered.
Yeah.
Why not? The factors we have all talked about here. How do you buy it? For health, use M-TIBA. You go to our website, you go to an app and things like that.
However,
Yes.
what we've learned
Yes.
is that technology does not change behavior.
No.
Technology actually, if you have a culture of fraud,
Yes.
put up the technology.
Yes.
All you've done is just maybe systematize and digitize
Yes.
the fraudulent behavior. So
Especially
you can't
because
escape.
fraud is an inside game.
Exactly. You
If it's
you
inside.
cannot escape the need to do
So-
the education
Yes.
and to work on the behavior change.
I would say education is key. I think we have agreed there's a big gap there. But I think there are even levels of fraud that there is insider fraud. There's just general fraud. If I find this door open and I find this phone here, I can pick it up. But let me just 1 second.
Somebody
Just
from the inside opened the door.
it depends.
Left it
No,
open.
I'll
Thank
give an
God. Amen.
I'll give an example, a simple
Please
one.
continue.
I'll give one example about the way in health insurance, we've been working with these health insurers to at least avert some general types of fraud that were initially seen before. So one way was that used to be seen was some providers used to create fictitious claims, like in it's not only in healthcare, it's in across. So someone would just say CT had visited, yet CT is seated at his house, drinking his black tea, whatever that
Favorite beverage.
the favorite beverage, and submit it to the insurance, and the insurance would be able to, okay, yeah, it's coming from this source, we will pay it. Number two is someone comes, he comes because they all both wear specs. He says he's CT, and he says, I want to be treated, I have this insurance, and they say, okay, yeah, you look alike to a certain extent, with
More or less.
more or less, because I can't remember as a hospital,
Yes.
because I see
Really?
hundreds of people,
To
and you
the-
get
to
treated.
the point where they all look alike at some point.
Yes, and so simple technologies like now digitizing, like what we do at M-TIBA, you use the biometric, and you don't even need a card. You just need to put your finger there. That's the only way they can start the treatment, and that means I have to be there. If it's an insider where I collude with the hospital, that one you can't avoid. If you know that.
You don't understand, there's something that Wanjiru said,
Yes.
that technology doesn't change people. It actually does. It actually does.
Behavior. Yes.
Yes, it changes. You see, why I say people is because your behavior is determined by the way you think. Now, when people talk about behavior change intervention, they don't point out, but you actually want to change the way people think and the way they look at things. Before Zoom became a byword for everything, and even now that it has become precisely that, if you observe carefully, if meetings were supposed to be physical, because we've accepted Zoom, that eliminates a lot of travel. In short, costs associated with travel reduced. Office space associated with face-to-face meetings and people doing business in person reduced. The process of adjusting to this is you changing.
Right.
But you see, people
Let
didn't
me
change
correct.
just because
Let
there
me
was
correct.
Zoom.
Let me qualify.
There had to be something else. There had to be another intervention
Eric.
that then made you use technology.
Allow me to qualify what I was saying. I was talking about fraudulent behavior And the notion that by introducing a digital process, biometric process, we are going to eliminate the fraudulent behavior. And the argument I was advancing is what the evidence shows us when you look at IFMIS in government. IFMIS was introduced in part to reduce fraud and
increase efficiency,
to reduce the kleptocracy, right? And even worse example is our elections, biometric registration and transmission of results and all of that. But because we didn't deal with the behavior, and possibly the systems were not, soundly implemented because there were loopholes in the electoral process and also loopholes in IFMIS. It's digitized to a point. But the point I was advancing is we still need to deal with the behavior. We're a low trust society. This is going to make it very difficult to reach the full utilization. I imagine there's fraud all over the country, all over the world,
correct,
but not at 40%. That is extremely high.
Why do you think we are that way inclined? It's because we are poor.
Oh,
yes.
That is so not true.
Oh,
poverty is not a driver of fraudulent behavior. Because then
poverty.
What you are implying is that the rich do not steal. In our setting, the rich steal the most.
You ought to have asked me.
Poverty of what?
Yeah, thank you so much.
You're living out
we didn't finish.
this personality has been lived out so well today.
Whatever. Talking out. It's called talking. It's called talking out of both sides of your mouth, or both heads in this case.
Yes.
You know, Ajiro, there's an entire discipline called psychology that has focused enormously on simply understanding how poverty affects the mind and what it is that you eventually have as a byproduct of it. What you are referring to is what other people call a poverty of spirit. That poverty of spirit, by its very nature, brings about a situation where someone doesn't have much to hope for and so doesn't have extremely high standards for almost anything because they've essentially given up. Now, many Kenyans are at that stage where you may think they haven't given up, but they have. They've accepted their lot, they've accepted the situation that they are in, and they are quite content to do what is necessary to just stay alive and to keep moving. Now, circumstances have brought them to that particular position. And when you say thinking, there are people who ordinarily would not even consider any criminal activity. But if you live in a country like ours, where criminal activity and thought and normalcy are more or less the same thing, where do you put the dividing line?
Siti, can I say that's a discussion for another day?
Yes, I was coming.
Because I was going to ask a question around this product, M-TIBA,
yes,
and also, this great move for insurance companies to cover the majority of Kenyans.
correct.
Are you looking at chamas, associations? Because a lot of Kenyans, maybe even SACCOs, a lot of Kenyans save and deal with their finances through these
groups, yes,
in these groups,
which actually have formal structures.
right?
Yes,
and they are also a big source of our of culture and behavior change. So that if you can
even controls, yes,
if you can penetrate there,
yes,
maybe you'll have very high uptake of these products.
yes.
So
And
is there a benefit if I came
Through a chama.
yeah,
through
we
a
can.
chama?
I can talk to you on the side for your chama. I can come talk to your chama about our products.
On the
But
side?
definitely,
Yeah,
yes.
yes.
We know that these groups exist. We know, especially even the traders, they have very tight, neat structures, which from the outside look there's no structure, but
But they exist.
They exist. And let me tell you, these guys are awesome. And in terms of how they organize, how they create controls, behavior controls. They know who is the errant one, and they also have ways of assisting them. And they have systems to help with insurance, healthcare funding. But it's not sustainable because one of the members could wipe out. So definitely we are targeting these chamas. And back to the technology discussion, just to come back in terms of behavior, I agree with Citi. It changes behavior. what technology needs to do is also keep evolving. Because in this example like Zoom, you found it could help change behavior. It could work from far, but people started cheating the system. So you started finding people either switching off or doing some things. So you see the features of this type of technologies improving to catch up with the change in behavior. So even as M-TIBA, we do the same. So the biometrics is one level. 2 is now to involve more technology to be able to help in fraud detection, behavior, just trying to advise even insurers how to design products. And we have seen this immediate implementation of technologies like us. You see efficiencies. I know you talked about, there is efficiencies, but the bigger area is to get more people covered. And that's what we know, that the more people are covered, the more dignity they have, because there's a big issue about being in a harambe. And you've asked,
we all know.
Yep.
I am affected by
know.
cancer,
Yep.
not infected, but affected directly. And we know the indignity. It's like
Of seeking help. And
of seeking
support.
help. And of course, there's the natural reaction like, you should have known. You know, it's like, hakona gari. And they're coming to ask us for money. You know, it's... But if the people knew that if I had some insurance, again, insurance is not meant to cover everything. That is another misconception. It's meant to cover what you pay for. So you need to know what it's paying for, so that you, in your planning, your financial planning, know that in the event that I get this medical emergency,
Yep.
I know I am covered to this
extent.
and I already plan on how to supplement the difference, because that's another notion where even we see the struggle that even if I get NHIF now, I'm assuming it covers everything. It doesn't necessarily cover everything. You need to get to know more details about what,
the particular product
about
that you've
what
taken.
it covers. Yes.
Now, from the M-TIBA platform,
Yes, yes.
am I able to actually see the various products
Yes.
and what exactly they cover? And then am I able to regularly keep refreshing my memory? Because I know, well, I went and took this 4,600 brilliant policy through M-TIBA, and I heard that it covers up to 70,000 shillings, blah, blah, blah.
Yes.
Do I know exactly how much, and I mean, what it covers?
Yes.
And can I keep going into M-TIBA to check?
Yes. So there are 2 ways to check for M-TIBA policies. So the number one is to go to our website, it's healthcare.mtiba.com. The second one is through our partnership with M-Pesa. So they have this new super app where they have many little apps inside. So M-TIBA is also there. So these are the 2 ways you can be able to access M-TIBA, healthcare.mtiba.com, or go to the M-Pesa mini app, buy healthcare there. When you look at it, we show you the array of products that we have, and it's beginning to build. And when you click on the product, you will see everything, all those things that used to be in
One big booklet.
booklet. Essentially, as I said, with design, with technology, you're able to show everything. Like, what does this cover? Is it outpatient? No. Is it inpatient? Okay. Up to even the top highlights of what we consider these things that people catch people. The exclusions, you need to know what it excludes, the waiting periods, which is another quagmire that keeps the friction between the insurance and the customer. And so this, especially waiting periods, exclusions, you need to know what it's covering and what it's not covering. And you can see it all on the M-TIBA app.
On the app.
And it tells you easily what is the price immediately. So am I buying for myself? Okay. I can check, do I want 75,000? I want 100,000. I want 200,000. I want 500,000 limit.
And how immediate is it in terms of now your access? If I'm on it now, for example, and I see something that, okay, this could help me out, or it could help a member of a family, etc., etc.
Yes.
I do the payment.
Correct.
Can I go to hospital tomorrow?
And that is the thing about. Remember, insurance is not for buy and use. It's not cash and carry. Insurance is a protection. So you don't buy it when you're sick. And I think that's also where the misconception comes in. And that's why the insurers or how the products are designed is to put waiting periods to also protect the insurance, because if everyone falls sick and buys insurance, then there would not be any business. It's essentially you're buying to use. So that's why you see they have some waiting periods. But generally for all insurers, if you buy it on the M-TIBA app, the standard waiting period is 30 days for inpatient hospitalization. But if you buy it today, once it's active in about 24 hours, if you have an accident and living here, you're covered.
Okay.
Yes. So it covers accident immediately. Yes, yes.
A quick one then.
Yes, yes.
Also looking at the bite-sized economy, because
Yes,
quite a lot of people operate within that bite-sized economy. 20 shillings here, 50 shillings here. And we've also seen that, again, other organizations making it possible for you to be able to consume something with a smaller amount. Are you looking at something like that you can pay on a daily, 20 shillings for the person who is bringing in, has an income that's regularly flowing, 20 shillings per day kind of thing, 50 shillings per day? Because I think really that would encourage people to say, okay, look, I'm not asking you to pay 4,000 bob, because let's be honest,
I don't have
4,000 bob, I don't have it,
I
forget it. And if I did have it, likely that there's 20 other things that need that 4,000 shillings.
City was talking
Exactly.
about. Yes.
So since there's so many that operate within this bite-sized economy, is there an option to have, a little bit per day that could, count up to something at the end of the month, and I can say this can go towards my insurance?
Yes. And that is the thinking we have. We currently don't have that in what we do, but we know we are going to release it soon for the same reasons that you're saying. People would be willing to pay the 20 shillings per day, 30 shillings per day. And also we are now trying to design this with our partners as well. But it comes back to the other conversation of value. What we are saying, what value, because remember even that 20 shillings would have gone into something I would have bought in the kiosk or something. So it's also trying to explain the value to the educate people why that 20 shillings is important to you. And I'm back to the day when airtime was a luxury. Now it is a basic need. And you can find even people, even Skiza tunes are almost considered a basic need, because you're deducted, I think, a certain amount of shillings per day. Yeah. So people love So again, we as the M-TIBA team with our partners are thinking that's where we want to go. Yes.
Okay.
Yes.
So as we conclude the conversation, Dr. Harry,
yes.
Again, how can people access more information about M-TIBA? You said one of them is the Safaricom app.
Yes. So on the M-Pesa Super M-Pesa app. So there's a Safaricom app and there's M-Pesa.
Yes.
The M-Pesa Super app has the M-TIBA app inside it. Or you can just go to healthcare.mtiba.com, and there you'll be able to see the products, play with them, look at different options, and it costs you nothing.
You can simulate.
You can simulate up to the point where now you say, I want to buy, and you say, okay, now at least I have this. So go on the app, go on our website, healthcare.mtiba.com, simulate, see what products we have. It's true, they are as low as 4,600 per annum for as low as that. But also you could text, if you have your phone, your listeners have a phone, you can text SPICE to 20253. It is free of charge. We will call you. We will answer all your questions in regards to health insurance. And yes, and hopefully working with you guys would also educate people more.
That is very important. Constant awareness creation. And we thank you very much for coming today. Dr. Torooti Mwirigi is a Sales and Marketing Director of M-TIBA. He's joined us today, this very, very important day. It's World Cancer Day. We're talking about the cost of healthcare and the importance and the need to take up medical insurance. That's the conversation we've been having. Keeping right here for more. So, Doc, you'll come back soon, yeah?
I will definitely come back.
Good.
Yes.